So I'm Sathish Sankarpandi. I'm in a rare and privileged situation to actually be in both the sides of the equation, where in one side, I'm actually creating all these large language or really complex prediction models predicting treatment response, so individualized treatment response for heart failure patients. And on the other side, I'm actually taking this information or the clinical insights, putting that or packaging it in certain way that people can understand in their home, even though they have learning difficulties, they have language problems, they have other accessibility issues. So in the next 20 minutes, I'm just gonna go through some of the aspects of both the sides of the equation, and we will see how we attack the problem. Right. Before I go into the case studies or the applications, and I just wanted to speak about this. The software has gone to a tectonic shift at this moment, and this is very important. Is because currently 25% of all the code is AI generated in the Google. Um, 25% may seem very little, but at the scale of Google, it is billions of lines of code that is written by a computer basically, and it is then reviewed by humans, and then it is gone through it. And what this is actually helping us to do is actually creating us to develop things and deploy things at a grand scale, and at a greater velocity. And what we are getting is we are getting 6x fast development and deployment, and this is very important critical infrastructure for everything we're going to speak next. Right. So, as a first topic, I'm going to speak about IK for CBD. This is a precision medicine initiative in the European Union. It's the world's, no, Europe's largest heart failure study. The reason why it exists is because there's more than 85 million people affected with cardiovascular disease, and with heart failure is one of it. And heart failure has 50% mortality in 5 years. So people having heart failure would die, or 50% of them would die in 5 years. So it's a serious disease. And what is currently happening in the current clinical pathway is like, okay, you treat everyone are same. So for example, drug X, you give it to everyone, and it's supposed to reduce outcomes or improve outcomes. So that's what they're doing. But what we said was, okay, these drugs have to be individualized and given to people who would need it, and we have to increase the dosage or decrease the dosage based on what is required for them. And then that's basically why ICAT for CBD exists. This is We formed a partnership between 38 international partners. So this is an Europe Union project. We have public and private partners. So we have lots of universities like University of Aachen, Maastricht. We have some universities from the UK. Then we all have big pharma companies such as Novo Nordisk, AstraZeneca, Eli Lilly, Bayer, Philips, and all those people. They're very important because all of them have different kinds of data. And we wanted to do if you want to do a truly individualized cardiovascular or any sort of precision medicine, you need lots of data. So we have collected almost 1 million data points that we just pooled from various different sources, and we are going to use that. And this was funded by European Union, and it's 22 million funded. Right. So, and the key objectives are, of ICARE for CBD is accelerating early diagnosis. So, can you find out people who are at higher risk of heart failure, and can we develop a model for it? The next one is, okay, of the people who are at risk already, who should you prioritize? So, can we risk stratify people? The third one is most interesting one. So, predicting patient responses. So, predicting drug responses. When you give a drug to a patient, how are they going to react to it, and whether it's going to give them more harm, or it's going to make them better. And the last one is, we are doing all of these things with patient advisory board. So we have a multinational patient advisory board. They all have heart failure. So we have brought all these people together. Right. So oops. Sorry, I want to go back. Sorry. Sorry. Right. So yeah, so now I said, because we are a big group of people with lots of data coming from various different areas, but there's this few problems with it, like patient records in one area or one organization. If you want to move to another organization, there is a regulatory barrier. You have GDPR, there's UIA Act, there's so many other regulatory barriers which won't allow you to move the data across. And so if you want to do a truly individualized prediction, how would you do it? Because you have to pull this data together, bring it together some way. And how would you even do that when you have all these regulatory barriers? And we have to remember one thing: all these pharma companies, they have proprietary data. They don't have, and they don't release those proprietary data, because the value of the company is based on that. So how would you access it? So right. So that's why we developed this data clean room. So what happens is, on the left side, you can see they are the data owners coming from various different organizations. So you have organization A, it could be AstraZeneca; organization B, University of Maastricht. It could be organization C, Maya Clinic. They all have their data, and what we have in the center is a data clean room. What it does is, basically, this environment will allow to run analysis. But what these data owners will share is only the metadata. They won't share the real data. So they'll only share the data dictionary to say that, okay, our data has these parameters, and these are the things that we have. And it is sent there. And we, as a researchers, we say, okay, if you have these things, okay, these are the four different data sets I wanna access. We say to the data clean room says to the data owner and says, okay, fine, okay, if you want to do that, so what sort of analysis you're going to run? Okay, we want to run this analysis. We say to data clean room, then the data owners approve it, then basically it runs an analysis, and we don't get to see the data at all we see is metadata. Say, okay, these are the different variables, or these are different columns of information that you have, and all we get is just an output to say, okay, we have run this model for you based on your code, and this is the output we got. And this way you can still keep your proprietary data with you, and you can still share. So that's what we did. So yeah, it works. Okay, that's one side of the problem. There's another problem. Okay, now you have the data, you have created a model, right? Fantastic. Now you want to deploy it in various different countries, and or various different hospitals, and each of those hospitals would have very sensitive data, and they don't want to give the data to the model. I mean, yeah, if you have a one universal model, they are not going to let their personal data or private data into the model to see, because it's a risk of people can take it away, and there's different private companies involved in it. And how do you do it is, we use something called a federated learning methodology. So you have different models. So you develop a model, and we locally deploy these models. So there's replicas of models deployed individually. Say, for an example, you have 7 hospitals, you deploy 7 models in each of those hospitals. And then what you do is, you have a central model which is just monitoring all of those things. And if you want to update this local model, you can update it, but all you do is just send them the model weights. You're not going to see any sort of raw data. So all the data is going to stay within that local environment. So if it is a local site A, it's going to just stay there. So if you want to speak to USA, it's still fine. The model still works, but the data never leaves. So it's going to stay there. And then whenever you want to change the model, you want to update the model because of other research, you can still do it by model weights update. So that's how we solved it. So now we have two things. So one, we know agentic AI. We have lots of really good models that we could create. Now we have data. We have the infrastructure to actually analyze the data without seeing the raw data. So I just want to go through some of the examples, or some of the things that we did beyond this. So one of the things is automated clinical report extraction. So you have an unstructured and siloed doctor notes on the left, and you can see doctor's writings is really difficult to understand. And what we are supposed to do is read that and try and say, okay, this person has a particular kind of heart failure, say, I don't know, left ventricle fraction or something like that. So these are all very, very different because doctors don't write it in the same way. They are very, very, ways of writing the notes. And how would you, can you use an LLM to actually read these notes and make sense of it? So we did that. So we took 2,000 reports from 1,000 unique patients. We took angiography and echocardiography reports. We gave it to an LLM, and when I said LLM, there's many LLMs. We want to evaluate which is doing very well. So we gave it to everything. So everything that is available in the cloud, like such as cloud, Anthropic, ChatGPT, all the Gemini models, everything, and also all the local models that can actually run in your computer or in a desktop. And what we found was, we could classify a lot better than humans. We got an accuracy of 87 to 100%, and we could classify culprit vessels and LVF, which is left ventricular function, very, very easily. And we published this paper, in before a month. It's all in European Heart Journal. The next one is very interesting and is very close to my heart. This is personalized heart failure treatment. So, what is the current methodology or clinical pathway? Is basically, if you have a heart failure, there's this four foundational therapies that doctor would give you. There's beta blockers, SGLT2, RAS inhibitors, and MRAs. So if you have a heart failure, the guidelines say that you have to give all this four medication, okay, and up titrate it. Basically, you have to give more and more until the patient tolerates. Okay, that's what the current standard of the clinical guidelines is. And that's supposed to improve outcomes. So if you can see, this is one size fit all. So just give everything until the patient tolerates and then stop. But we know not all heart failure medications help everyone in the same way. You know that. And we also know some patients may benefit more from certain drugs and than others. And we know the goal is better outcomes with fewer side effects, and we have to choose the right drugs at right dosage. Yeah. So now, because we have quite a lot of data, can we do this? Can we actually personalize heart failure medication? Yeah, we can. Right. So what we did was, we took 4 studies because there's lots of data coming from us. So we took 4 studies, and we had about 3,081 patients and 23,982 patient visits. We used a causal machine learning framework. So this is not a black box LLM, because you have to interpret. If you are creating a model, okay, you have to interpret what the model is doing. You can't simply use a model from the cloud like Gemini or something like that, because it has trillions of parameters and you don't know what it's really doing when it will hallucinate. So this we created a causal machine learning model, and we said, we can predict individual treatment effects. And one of the targets we had was, okay, can we predict the median 90-day risk reduction? Can we predict 90 days risk? And let's see what happened. Right. So the key findings were, of course, we found that treatment benefit varied substantially between patients. Yeah, that's what we found. And so the median 90-day risk reduction, MRA had a very strong benefit. We had 1 point, if you reduce MRA by 1.5%, because this is all individual predictions, but I'm just averaging them for all the patients to put it in the presentation. So if you reduce MRAs by 1.5%, it is going to have a better outcome than actually giving all of them together. Second one is beta blockers. So if you reduce them by 0.4% in an average, but for each patient differs, you have a modest benefit. And also, RAS inhibitors did not have any effect. You don't have to give them. And loop diuretics increase risk. So don't ever give that. So and also we found few other things. What are the combination of drugs that's actually helping people? So that is also another interesting results. We got this paper which I wrote. It's under review in Lancet Digital Health, so it will be published very soon. There's quite lots of information in there to see. Uh, right. Now, all we saw was, okay, we have created a really good infrastructure to collect all the data. We created precision models that will actually predict individualized treatment response, personalized medication, and all those things. Oh, these are all very great. But there's a key problem. So I was told when we started IK for CVD, The reason why we were brought in was, so there was a gentleman who just came, presented. He had a heart failure, and he presented to emergency department quite frequently, and the doctors didn't know why he was presented so frequently, because we are doing everything we could, and they couldn't figure out. On one occasion, they found that whatever medication was given to him, he was not taking it all. So it just comes down, you can have all these really great models, but if people don't understand why the prescription that they're given to them, it becomes very, very difficult. And once he started taking medication, he didn't come to ER for the next 10 years. So so that's so it is very, very important that you have all this complex clinical insights that's coming out. You have to deliver it in some way that reaches people home. And also you have to think about people with varying language difficulties. They're multilingual. Some people have accessibility issues. How do you cater to all those things? And that is where VirtTuri comes. So the final bottleneck is, in healthcare, is not calculating risk but communicating to patients. So yeah, with literacy and digital and language barriers. So at VirtTuri, what we do is, we take this dense clinical information, and we take that and rip it apart, and produce personalized information based on this information, based on dense clinical information we've got. And we do that. We cater to various people by translating this information in their language so that they can understand better. We also do various avatar technology, so people who can't really read, we have a video sequence that they can actually see. We can't, and that's one thing. We also cater for people who have deaf and dumb. We have sign language. We also send audio messages on text. Right. This is okay. There's two parts. One is taking this dense clinical information and breaking it apart that people can understand. But how do you make this information that you break it apart reach people? So, and that's why we came up with Recap Health. So that is our proprietary application. What it does is basically, just with this, with your NHS number, it can actually package various different information that you require. Usually, people with some kind of an issue like heart failure may have diabetics as well. They may have other comorbidities. So what we do is, at Recap, we take all this information and package it, that are personalized for that person. So whatever is required for them is only sent to them. So, and we did a small validation, and with over 100 user cohort, and we are receiving 95% acceptance rates who rated good or very good. I just wanted to move into another case study. This is one of a very interesting projects that was done in Bradford District Case. So the LEDAR study showed that people with learning disabilities die 28 years sooner than the general population, and 24% of these avoidable deaths are due to respiratory disease. And we were thinking, oh, why this is happening? And it is all because in Bradford District Care, there's a multicultural population, and usually the information is sent to them in English. And just even taking inhalers, and or using nebulizers properly, they couldn't understand it very well, so they are not using it in an optimized way that will actually bring more benefits. So what we did for that is basically develop an evidence-based MDT pathway. So basically trying to figure out, okay, what the problem is. Identification of risk factors is what we did first. And the next one is, okay, once you identify the risk factors, okay, we created a simple to follow, bespoke supported avatar care plans, and and accessible and user friendly multilingual avatars. And then we send that using our Recap platform, and then it is also available in their website for people to see. So we did this in various different languages so people can understand. So for a start, we only did it in Urdu and Arabic. And what happened to that was, we got 54% reduction in chest infection just by doing that. And we also got 70% reduction in hospital admissions. We got HSA patient awards for this, and we got the nursing times award, and we also are featured in NHS score 20 plus. So very simple, but very powerful. The next case study is slightly complex. So So again, for cardiac patients who are living in Midlands, so there was 24 NHS trusts, and they want to provide information that will actually help them, or better help them to live better with heart failure. And the problem was, we have to translate this whole, I mean, so much of information in 12 languages, and that is going to cost quite a bit and time as well. And in NHS, there's not so much money. So how can we do something? Because we have AI and other things. Can we do something about it? And what did we do? So I just wanted to simply, go through this quickly. What is the current state of play of clinical translation? So you can use a professional manual translator. So there are clinical translators and there's just normal translators. So usually clinical translators are more expensive than non-clinical manual translators. They are very time consuming and they are not easily scalable. And for really scarce languages, you won't even find a clinical translator. So it's very, very difficult. And this is one of the stark things where we found that all manual translators are not 100% accurate. Okay, so what about AI tools? So no single AI translation model is 100% accurate. So anything that is available is nowhere 100% accurate. But we also found that, okay, there are different models who are will have better accuracy in certain languages. So you have to figure out which model to use for which language. So, and that's what we did. So we created a hybrid translation system. So because of these problems, we know we can't give everything to a professional translator. So what we did was we created a hybrid translation platform. What it simply does is, you enter some text, or you upload a document. You basically select whatever language you want, and then it gives you the output of it. Right. Okay. Come on, quick. And I'm just going to skip through that. Right. So you give an input as an audio, video, audio or keyboard. Then you have a hybrid translation. So what we are basically doing is, any sort of information you want to translate it. We will first use an AI system to translate it, then give it to a professional translator, because we think it's going to reduce the time. And we did a study on that, which I will show you. So what we did was we took 1,000 documents. We want to compare if this hybrid translation methodology is working or not. And we gave it to professional translator to see, this is the translated material. If you want to translate, I mean, what sort of edits you're going to do. So once translated, how much effort they are putting in to actually change the content, like changing the words. So how much post edit were they doing? And we found that 60% of the translation was kept intact. So nothing was done, nothing was changed. So if you take a hybrid translation methodology, so you are basically saving 60% of the workload, and it's just professional linguists can work 2 to 3 times faster. And we also found there's a 40 to 60% cost reduction per document. So it's working fantastic. We are not just relying on AI to do everything, but we are augmenting AI in certain way and bringing human in loop, so that the information presented is accurate. So that's a very, very key element. Right. So as the challenge of NHS Midlands, we use this hybrid translation. We translated all these materials into 12 different languages, and we have got 220 different avatar assets. And when we did a small validation, 96% of patients found the platform very, very useful. Right. That concludes. So, Joe, I want to say in a summary, do not ignore AI. AI is no more a peripheral experiment. It is a core infrastructure. So analytical models like such as iCare for CVD, they are very, very important. We are doing everything individualized, personalized, and just doing that is not enough, because that is not going to save lives. You need a delivery system, and we have VirtTuri in recap. So I just want to end with this. So we are moving healthcare from reactive to proactive, personalized, and equitable care. Thank you.